She's a 13-year-old female with complaints of deformity in bilateral wrist, insidious in onset, observed since 3 years, and gradually progressive. And she has no complaint of pain and no history of fever, trauma, constitutive symptoms, or any family history. On examination, there is dorsal deviations in bilateral wrist, dorsal and ulnar deviation in bilateral wrist, and shortening of forearm. On palpation, ulnar salad is not palpable. There is no tenderness or local rise of temperature. There is a 1.5 into 1.5 centimeter bony swelling on the volar aspect of the wrist. On movements, there is absence of palmar flexion and radial tilt. There is 25 degree to 90 degree dorsal flexion on both sides, and 40 degree to 80 degree ulnar deviation on left side, and 30 to 60 ulnar deviation on right side. Along with that, there is a marked laxity at both wrists. And the length of forearm is 14 centimeters compared to the arm, which is 26 centimeters on both sides. Pronation, on the left side, there is no pronation. There is supination from 35 degree to 80 degree. And on the right side, there is movement from 15 degree pronation to 75 degree supination. ठीक है, we can see just like this. अब पूरा अंदर करो, पूरा अंदर करो. इसको यहाँ पे जैसे.
See, as Alaric said last time, you must not let the wrist drop. That's what I was telling Swapnil from here, that the patient, though he has got synostosis, is able to do pronation because of wrist drop. So therefore, that you should not allow this to wrist drop that way. It should remain in the axis of the forearm. Understood?
It is not coming in the axis of forearm. It is fixed in the 25 degree dorsiflexion.
Then she is trying to do that forcibly. So just show properly what is the pronation without wrist drop. You should not let the wrist drop. Then what is the point?
When you check these, you must always do both active and passive. So we always talk of this active and using the pen as a goniometer to find out. But as we have seen before also, a lot of times they compensate. Of course, by the shoulder is the first, but if you put the arm against the body, then that prevents the shoulder movement. But more commonly, they use the wrist laxity to show that they have got pronation supination. Actually, there isn't. So do both the tests. Do one is the active pronation supination using your pen as has been described, but then also passively holding the distal radius and ulnar to actually find out if there's pronation supination at the forearm, or is it happening because of this compensatory wrist laxity that they develop over time.
So if I do passive, holding the distal radius metaphysis, then eliminating the wrist laxity, there is less of supination, and I find there is a little bit more of pronation. On the left side, it is from 50 degree supination to 30 degree pronation, and on the right side, it is fixed in 0 degree to up to 70 degree of supination. So there is a lateral rotation of the carpus and hand.
What about pronation on the right side?
Pronation is not possible. It is up to 0 degree only.
So whenever you describe pronation supination, describe both of them. The active one, where they have compensation from the wrist, and then you have the passive one, where actually holding the distal radius and ulna and actually measuring the amount of pronation supination. Okay, then?
There is no distal neurovascular involvement. The sensations and pulse are normal, and grip power is also 4+. So I would like to give a provisional diagnosis. Most likely, it seems to be first I would like to say a post-traumatic or post-septic physeal arrest of the ulnar part of distal radial physis. Second, I would like to keep idiopathic madelung deformity.
This is a bilateral deformity, right?
Yes, sir.
Then how common is it to have an infective sequelae which is almost equivalent and has left a similar, what do you call as a scar or something of that sort, deformity?
It's going to be very rare, but if there is a fall on both hands, I mean post-traumatic also, there could be, but there is no proper history supporting that.
Generally, Harshit and everyone else, when you have bilateral involvement, infection, trauma comes lower down on the list. Yes, of course, there are always potential diagnoses, but the very fact that it's occurring bilaterally, it's almost symmetrical. There's nothing to suggest there's infection when she was young. There's nothing to suggest she had an injury. No one will fall and get such a trivial trauma and land up with something like this. No? So if she's had a significant fall, you'll make out. So it's not that we are saying that bilateral trauma, bilateral infection can't occur, but that's much lower down on the list. So if you list sepsis first or post-septic sequelae first, that's very worrisome.
What is the position of the radial styloid process to ulnar styloid process bilaterally? You said
The ulnar styloid process was not palpable, but there is a bony prominence on the volar aspect of the wrist, most likely to be ulnar styloid, but we'll have to confirm by radiography.
So when you say bilateral forearm involvement like this, what are more likely, Harshit?
Congenital disorders or
Congenital is
syndromic,
possible, yes.
And
But was it present from birth?
no,
Because congenital means present from birth. So it's very rare. It's not that it's impossible. You can have deformities which are present at birth. They're so mild you can't make it, and as they grow older, it becomes obvious. But when you have something which occurs little later on, a developmental issue is more likely to be the
metabolic,
problem. So when you use the technique of a surgical sieve to diagnose post-traumatic, infectious, developmental, neoplastic, that's a very broad categorization. So the first that comes to mind is developmental, isn't it? So rather than saying infection, is not correct at all. So the way you order your differential also is important to the examiner, isn't it? Yes. So when you have a bilateral involvement which has occurred later on in life, developmental disorders will come first. Then you can fine tune it to what developmental. So the first is use the principle of the surgical sieve, where you differentiate into what of these categories. Okay, so developmental is more likely first. Congenital is the second, then infection, then trauma. Yes. So then in developmental, what is likely?
Are you able to palpate the olecranon, the tip of the olecranon and the entire ulna, or no?
so
What I'm trying to ask in short is, you said you cannot palpate the ulnar styloid, and I don't see any reason why you shouldn't. Because if you can palpate the entire ulna, which is a subcutaneous bone, then you should eventually reach. What sir is trying to ask is there any sort of a dissociation between the distal radioulnar joint?
you start from the olecranon, palpate the complete ulna is subcutaneous, then you'll go to the ulnar styloid. See on the right side.
So then you're able to make her do that and show it to the camera.
And also the radius and ulnar lengths, which is also something very important in this case.
So wherever it ends, your ulnar styloid ends there. No? So you cannot say you cannot palpate, because as you rightly pointed out, it's a subcutaneous bone. So this is a subcutaneous bone. You start with the olecranon tip and you keep going up, and wherever it ends, that's the ulnar styloid. So it ends there. So you cannot say that we cannot. Where the bone feeling ends and now it's all dipping to soft tissue, that's where it ends. So you have to say that it's here, but it's short, because compared to the radius, so there is a discrepancy between the radial styloid and the ulnar styloid. Because it's subcutaneous. So you can't say I cannot. So what is the differential that we'll have first now with this revised sort of findings?
So first I would like to keep idiopathic madelung deformity.
Loudly.
Idiopathic madelung deformity.
Idiopathic?
Madelungs.
Madelung deformity, okay. Yes. What are the developmental conditions can happen which can cause forearm deformities, which are very common in fact? A lot of people are familiar.
In this case, is the ulna short or is the radius short? The radioulnar variance, is it a negative radioulnar variance or is it a
So on
normal?
palpation there is a negative radioulnar variance.
Means
In madelung, there is a deformity of the distal radius, is it not?
Yes.
On the lateral side. It is short and it is flexed.
So, but there is this bony prominence on the volar aspect, and I cannot palpate the ulna completely.
What is the
because
common
of the
developmental
carpus here.
condition which happens in children, which is familial, which is hereditary, which runs in families?
Familial, we saying familial, so familial के आगे दो शब्द लगाओ. Familial, yeah. Multiple, what? Now I Ah,
Familial hereditary
familial I said
osteo
multiple. See, multiple people are staying here.
Olliers and
What? Alliers? Ah, Dr. Niraj. Very good. Familial, multiple, what?
So familial, hereditary, multiple exhaustosis, diaphyseal eclasia, isn't that a far more common condition? So have you palpated for other bony deformities elsewhere in this child?
sir.
Have you asked the parents? Because we know that there's a familial incidence and inheritance in this. So have you asked the mother, father, first degree relatives, second degree relatives?
so sir, there is no other joint involvement and no other swelling.
No
in the-
other?
No other joint involvement. No
Joint. It doesn't affect the
Other, no
joint.
other swelling, and there is no family history of similar deformity in the.
Have you seen the proximal tibia and distal femur?
Yes, sir.
Palpation? And in the familial hereditary exhaustion, they are very tiny and small.
Yes,
But
as
there
I-
was a lot of deformity compared to a solitary exhaustosis.
So how old is she?
Have you seen?
13-year-old, sir.
13 years old. So do you feel for 13, of course it's impossible to say that, but for a 13-year-old, is she of the adequate height and stature?
She looks like short stature, but she has more height than her mother. So I would that's why I didn't include that fact.
But have you seen the exhaustosis? Have you
Yes,
really
after the
seen knee?
palpated, there is no other swelling in the knee.
Which areas were you palpated, Harshit?
So, distal femur, proximal tibia, and elbow humerus.
Ankle?
Yes, sir.
Have you seen the ankle? Okay, anyway, does she have exhaustosis all over?
No, sir.
It doesn't have anywhere.
No, sir.
Huh? Okay.
But still, that will be the first diagnosis, isn't it? No? Even if you don't have in the first degree relatives, nowhere else in the body, maybe you'll find them on X-rays because some of them are very sessile. Most of these areas are covered by big muscles. So if you have a small sessile exhaustosis on the inner side of the humerus, you'll never feel it. Distal femur, you might easily miss it because the growing parts of the bone, which are rapidly growing, distal femur, proximal tibia, proximal humerus, are quite easy to miss because they're covered with muscles. So your first diagnosis should be a hereditary multiple exhaustosis rather than a madelungs. No?
And it can't be madelung because you are finding the ulna is shorter there. I mean, there the radius is grown quite well, is it not?
So what happens in a madelung's deformity? Since your first diagnosis was madelungs, what happens in a madelung's deformity?
Usually there is a radial and volar tilt and disruption of DRUJ with positive ulnar variance.
So as Sir is rightly pointing out, when you have such a negative radioulnar variance, where the ulna is so short compared to the radius, why would madelungs be a first diagnosis?
It should be down second.
Huh? Yeah, so this is what happens, boys, same thing, Gaurav also, you had the same thing, a diagnosis given by someone, and when you come to a diagnosis, if you can't defend them, then you're in trouble, okay? Because I will straight away say that your friend has told you the diagnosis. So in fact, I would always caution you in the exam, please don't ask for the diagnosis. In fact, it is counterproductive. And that's what we were taught during our exams as well. The examiners are not so interested in diagnosis as how you defend that diagnosis. In fact, they're out to catch you that someone has told you the diagnosis before. And we don't need to know that. We don't need to know diagnosis. So in fact, you should avoid that tendency completely of asking your friends, please give me the diagnosis, because that misleads you so badly. I'll give you my own example. When I had my DNB exam, I had a case which the diagnosis was completely different from what I presented, but I could defend each and every of those findings, and the examiner agreed with me. And the diagnosis which was given was altogether different. So please don't go by diagnosis that someone has tutored you or told you, okay, there are 4 cases for your exam, ek madelung hai, ek clubfoot hai, ek ye hai, ek wo hai. That straight away biases you. If you can't defend that diagnosis, you're in trouble. The previous case also, you can't defend the congenital radial synostosis. Yeah? So same way here, madelung, you're not showing anything to prove it's a madelung. Any other x-rays there? So this is lateral, where's the AP? Okay.
Yeah, clinically it's difficult to say it's madelung unless you know the diagnosis. So clinically it is difficult to say that it is madelung unless you've been told that this is a madelung, because in that definitely I can't really find the head of ulna over here. The head of the ulna then should be more than that of the radius. But here it's not palpable. Is it not?
So, is there some amount of short stature you feel? So, you said she's taller than her mother, but
Yes,
despite that, because it
according
seems
to
so,
the-
it is very difficult to quantify it, but it seems so.
So, yes, sir. On inspection, she seems to be in a lower percentile for height, according to age, but on inquiring with the family and they have, she is adequate height. I mean,
But this can be some sort of a dysplasia as well, something else which.
yes, if I would have found that there is a significant short stature and tibia is also short, then I would have considered Lary-Wheel osteochondrosis with
Pardon?
Lary-Wheel osteochondrosis, which has mesomelic dwarfism and madelung.
Osteochondrosis. What did you say? What did you say? What
Syndromic
osteo?
association for madelung and mesomelic dwarfism.
I'm not understanding only what you say.
Yes, sir.
See, anyhow, so what do you do now? So see, always, Harshit, when you're presenting, come to common diagnosis first. Second is, please don't ever get biased by what has been told to you. You have to defend your own diagnosis on the strength of your findings. Yeah? And always assume that the common ones are more likely than the uncommon one. Okay, so that makes just sense that way. So what do you do further?
So I would like to investigate with radiographs first. And
Yeah, this is done.
So does it confirm your diagnosis?
sir, in the X-ray, I can see that actually there is positive ulnar variance, and the bony prominence which was being felt on the volar aspect was ulnar styloid, which is disrupted. The DRG is disrupted. And is there any other view?
The radius seems to have stopped growing. On the ventral side, it has gone down, and the ulna has grown up. So on the radial side, it is not grown, and it is gone into flexion there. But clinically, for you to say madelung, even I will not say that. It's very difficult because I can't palpate the ulna. I can't know whether it is the carpus that is coming up or is the head of the ulna. If I find that the head of the ulna is really out, then yes, surely. But otherwise, this is just a toll diagnosis. So don't say that way.
So how do you manage this?
Because the radiographs are not properly depicting the deformity, I would like to investigate with the CT scan before planning for surgery and get the routine lab investigations done to rule out any other abnormality. And for
When you have a complex deformity like this, to try and make sense of these X-rays and try and make a treatment plan based on these X-rays will be very difficult. So the decision making will be based on two things really to me. One is her functional limitations and what really she can and cannot do, and what does she desire to do and whether we can give her that. And secondly is how do we assess this complex deformity better? And obviously on the X-ray, you're not going to be able to make that diagnosis, that treatment plan. So a CT scan with a 3D reconstruction will give us a better idea because there's so many things going on here. There's a torsional problem as well. There is a coronal plane deformity. So when you have such a complex forearm deformity, we can't assume that on two-dimensional X-rays, we're going to be able to make a treatment plan. So what are the functional limitations? What does she desire? What can we offer her?
her primary concern is the progressive radial tilt of the hand, and she just wants it to be prevented, to correct it, and also further prevention of the radial tilt.
She doesn't know all those things. She's not a
rotations,
doctor. How does she know all that? She doesn't know about radial head and ulnar head and all. How could she tell you that? So what is her functional complaint? She does not know.
You can't say, I want my radius long and ulnar short. And will she tell you that?
No, she's not talking about the forearm shortening.
Correct.
I
So
mean,
what is
I'm
the
asking
functional
about the,
problem? What does she want?
Or what you want to give her, what are the problems and how you want to solve it. One is that the entire corpus is subluxated. It is not centralized to the radius.
She has no functional limitation and according to the rotation. Because of the wrist laxity, she is able to perform that well.
Why has she come? Why has she come to you?
Why, sir?
Why has she come to you?
For the coronal plane deformity.
For the?
Coronal plane deformity, which is progressive.
She does not know those words, Harshit. She does not know those. She's a lay person. She cannot tell you, I've got coronal plane deformity. What does she come with? She has come to you as a doctor to say, I've got certain complaints. What is her complaints?
Her complaint is a deformity in wrist.
Is a cosmesis, so it's cosmetic problem she has come
Yes.
for. She doesn't even know the word deformity. She knows that cosmetically,
It is
mera haath teda hai. So she's come to you for that.
for
na? So
cosmetic, yes, sir.
we have to address what she has come for. So she's come for cosmesis. What else?
They don't have any functional desire.
Right.
What-
So people come only for two things, either for cosmesis or for a functional problem. So she has no functional problems, you're saying. She's able to do everything that she wants to do. So she's able to write, do all her activities of daily living, everything. She has absolutely no complaints functionally.
on writing, for some time, she has some.
क्या
pain.
तकलीफ होते मम्मी उसको? क्या प्रॉब्लम है?
इसका अभी जल्दी में ऐसा हो गया 4 साल पहले
हाँ
4 साल पहले ऐसे हुआ
हाँ, लेकिन उसको क्या तकलीफ होती है?
ये दर्द करता है
दर्द होता है. सो पेन वन. और क्या? सब कुछ कर सकती है, वो दोनों हाथ से लिख सकती है, खा सकती है, सब कुछ कर सकती है. बेटा क्या लगता है, कुछ तकलीफ है हाथ में? कुछ भी नहीं. सो शी हैज नो फंक्शनल कंप्लेंट, शी सेज. सो शी कंप्लेन्स ऑफ सम पेन. Okay, she complains of a cosmetic problem, and she has no functional problem. So then we have to be very careful, because then whatever we are doing, we should not jeopardize her function further. Because whatever she has, either we should make it better or leave it the same, and maybe then sort of just a cosmetic issue. So it's very important to have shared decision making when you come with complex problems like this. We cannot be paternalistic and say this is what we should do, especially when it comes to upper limb, because the upper limb is for function, the lower limb is for walking, right? So in the upper limb, we are very, very keen about function. What are the functions of active daily living, activity limitations, or participation restrictions? So she doesn't have anything, she says. Maybe you need to interview her even better, talk to the child personally yourself, because sometimes some subtle things will only come up if you persistently ask them, or if a leading question is asked. Because openly they may not even say that. So it's very important to get the patients and parents' perception. What is the problem? Superficially, what I've seen here, now with this dialogue that we have had, it's mainly for cosmesis and some pain. Now, pain indicates that there was a significant deformity which is causing some fatigue. So there is some functional element to it. Because pain will not just come that way. You can't just press something and say because it's deformed, it's painful. So that means while doing something, something is causing pain. So there is some functional issue there as well. All right?
On writing for longer duration, she has pain in the wrist.
Of course she would. I would expect that. So as you ask the leading questions, so one is very superficially ask them, because you don't want to lead the patient at the beginning itself. But if they don't openly come out with it, then you have to probe each little element of activity limitation and participation restriction, right? So writing, what are the upper limbs are used for? All of that we need to know. So eating, writing, bathing, toileting, all of that is she able to do or not. Then we can come to a decision what we should do. Okay, good.
Comment on grip strength as well when you're talking about
Yeah, he said it's good, he said there's good grip strength, but then when it's bilateral, it's difficult, but unilateral is very easy to make out that one side she's really got good, because for her, now both the sides are affected, so she doesn't know what normal grip strength should be. To her, both hands seem the same. So she's happy with it. But when it's unilateral, someone will very obviously tell you that this hand I cannot hold properly because it's so deformed. But this hand I can hold well. Right?
summarize the case and what you will do about it. Just say that.
So this is a case of 13-year-old female with wrist deformity, bilateral, since 3 years, insidious in onset and gradually progressive. With after reviewing, there is a positive ulnar variance, radial tilt and dorsal tilt with absence of palmar flexion and ulnar deviation, radial deviation, and there is a significant forearm shortening bilaterally, and
She's also got a disruption of the...
disruption of radial ulnar joint.
That's extremely important, no?
I would like to evaluate with better imaging, and also I will like to counsel the patient again of the possible risks to the functional activity if any procedure is performed, and according to then.
What procedures? You're just waffling. What procedures will you perform?
So usually for madelungs, would like to do the excision of Vickers ligament and a dome osteotomy of distal radius to make it align the articular surface in the plane, and shortening of ulna and with the pinning of the DRUJ, temporary pinning of DRUJ, and
So, Harshit, in this case, you're lucky because when it's so badly deformed, even the examiner is looking blankly. So even if you say a few things, you give principles, because we know that what's going to happen is a lot of it will depend on further imaging. We know that the CT scan will tell us the three-dimensional deformity, which is not only in the coronal plane, but in the sagittal and in the torsional plane as well. So this is a complex three-dimensional deformity where even if you ask me or you ask Dr. Ruchita, who's the upper limb expert, we'll not be able to tell you in 2 minutes what is to be done. So all that you would say is that we are trying to improve her cosmetic deformity without losing function in this child. So it will involve some osteotomy and some shortening of some bone. That is all you can say. But are these principles you should be able to tell us, no?
Yes.
The only thing I would add here is when you have the carpal subluxed and the radioulnar variants so badly disrupted, it's always better to put forth distraction as one of the options to try and align it better by ligamentotaxis and then proceed with your osteotomy. So it gives you more working length also on table.
So how will you improve the cosmetics and function is to get bones aligned and to correct whatever subluxations are there. So how do you get bones aligned? Either by ligamentotaxis, by using osteotomies. So whatever is malaligned, you have to realign them, and whatever is too long, you have to shorten. Yes. So after you have looked at the three-dimensional deformity on a CT scan, I'll be able to then decide what combination of osteotomies